You can see all of it. All right, here we go. That looks like penetrating trauma. So chest trauma breaks down into penetrating trauma and closed trauma. That's pretty obvious stuff. On the exam, I'm not going to ask you for statistics. I don't like those kinds of questions. National Registry doesn't like those kinds of questions, but they fill your book up with statistics to make it fatter, make it cost you more money. Okay, as you can see, chest trauma, over 700,000 emergency department visits a year, 18,000 plus deaths. So that's like 25% of the deaths in trauma are thoracic injuries. It's a pretty significant number. There's the outside of the chest, the inside of the chest. Remember, when you're assessing a chest trauma patient, to assess the anterior and the posterior, that includes inspect, auscultate, palpate, the whole 9 yards. That's what it takes to assess a chest. Have a quick video later on of a doctor kind of explaining some of that. It breaks it up. Instead of you listening to me, you can listen to somebody else. Okay, those are the pieces, parts. Important things to remember here. We need an intact thoracic wall. We need non-fractured, need intact ribs, sternum, everything connected, so that when the intercostal muscles contract, that cause the chest to go out and up. That is how we create the negative air pressure inside the thorax, so that we have a pressure gradient and air moves from a higher pressure in the ambient air into the chest. Anytime we disrupt that, we're going to interfere with tidal volume. That would include any sort of injury to the diaphragm, a diaphragmatic rupture that would prevent the diaphragm from contracting downward. That's the second piece of the muscular movement that it takes to create that pressure gradient. Landmarks we'll talk about later. So let's keep scooting here. Those are the muscles involved. They're important. Know that they're there. They're not going to be on the exam. Okay, moving on past muscles. This isn't an anatomy class where I expect you to memorize every muscle in the body. When you take anatomy, you will do that probably. If I were the anatomy professor, I would make you do that because my anatomy professor made me do that. Important things physiologically with the chest, contents of the chest are the only structures that we have for circulation and oxygenation / ventilation. That's the heart and lungs, right? And the great vessels, those are extremely important. If we interrupt anything internally, we compromise circulation and respiration. Respiration, I'm using as far as at the alveolar level, the true respiration where we diffuse oxygen onto hemoglobin molecules and CO2 because of the partial pressure of the two gases. Once the oxygen is gone, the CO2 moves out of the bloodstream and then into the alveoli, and that air is exhale. That's all review stuff, hopefully. Okay. So mechanics of ventilation can be disrupted by chest trauma. Sometimes, if nothing else, just because of pain. If somebody has a large contusion to their chest wall, it's going to hurt to take a deep breath. We don't even have to have fractured ribs, just a big contusion, and and the patient guards, they hold back on taking a full deep breath because it hurts to take a full deep breath. So that impairs tidal volume. Tidal volume goes down, then moving on down to the alveolar level, respiration goes down. We have less oxygen available. How does our body compensate for that? We breathe faster when we have pain. So we're breathing more shallowly. So we adapt minute volume. When we lose tidal volume, we maintain minute volume by increasing the respiratory rate. So remember, tidal volume times respiratory rate equals minute volume. Minute volume is important. Circulation, if we have damage to the heart itself or to the pericardium surrounding the heart, then we compromise circulation, and it takes circulation and respiration to perfuse the human body. Okay, can end up from blunt force trauma. This is all obvious stuff, but we'll hit it for the sake of the video. Fractured ribs, sternum, bruising to the heart, bruising to the lungs, damage to the aorta, damage to the distal portion of the superior vena cava or the more proximal portion of the inferior vena cava, can essentially have penetrating chest trauma without having a opening through the chest wall by having a broken rib that lacerates one of the interthoracic organs. You see the same thing that you might with penetrating chest trauma. It's just the chest wall is still intact. And then in things like high torsion injuries, like rollovers, major side impact injuries, you could end up with aortic tears, aortic shear, so that the aorta is completely torn away from the heart. That's going to be up on the proximal portion of the aortic arch, around close to where the left subclavian artery bifurcates off of the aortic arch. Blast injuries, primary shock wave, that creates blunt force trauma. Just that major impact of sound waves nailing the chest, that can have enough energy to cause enough blunt force trauma to kill someone. And then secondary shock wave, that is when you have all the shrapnel that goes along with the blast, the nails and thumbtacks and glass and whatever else the IED manufacturer stuck in the bomb that impacts chest wall next. We can impair cardiac output. One way we do that, let's say that we have pericardial tamponade, that interferes with refilling of the heart so that the ejection fraction goes down, and that decreases cardiac output. That's going to result in decreasing blood pressure and poor perfusion of organs, including the brain. And ventilatory impairments. I've already mentioned this because I got ahead of myself. Shallow breathing decreases minute volume. How do we treat that? We treat that with assisted ventilations. We have this magic device called a BVM, and we can adjust for that shallow breathing by delivering a sufficient tidal volume to our patients. If they're breathing too slowly, we can assist that to a proper rate, and that would be in an adult 1 breath every 5 to 6 seconds, just like with CPR. And then if they're breathing too rapidly, again, we can bag assist at that breath every 5 to 6 seconds, and maintaining their minute volume for them despite their inadequacies in the function of their bodies. Excuse me, and air in the pleural space, pneumothorax, that compresses the lung itself and decreases tidal volume. We'll talk about how we treat that later on in the lecture. And then blood from damage to the organ of the lung itself. The body of an organ is called the parenchyma, and injury to the parenchyma of the lung can result in bleeding. That's going to fill up space, going to occupy space within the lung, and that is going to decrease respiration because tidal volume is impacted. We need a surgeon to fix that. All right, atelectasis, remember that's collapsed alveoli. The less alveoli we have available to participate in respiration, the less perfusion the body has, and where was I headed with that? The less perfusion the body has, the more poorly it's going to function. And if organs go without oxygen long enough, if they're become hypoxic enough, then other than the brain, they can move into anaerobic metabolism, which causes a buildup of lactic acid, which is going to eventually result in the death of our patient. All right, scene size up. Gloves on, scene safe. Is that enough? No, let's expand that. We're not struggling to memorize things in EMT class anymore. Hopefully you're not struggling to memorize EMT things. Is there anything here that's can potentially injure me or my partner? Is there anything here that could potentially kill me or my partner? Remember something to throw in here from the terrorism side. A big thing in terrorism is to place a primary device that explodes, and you have blunt force trauma and penetrating trauma from that, as we previously mentioned, and that gets responders to the scene, right? We show up on the scene, fire shows up on the scene, police is there. There are potentially dozens of people there doing their thing, and then secondary devices go off. The thing that's better than killing a bunch of people to a terrorist is to take out a bunch of the people who take care of those who were injured in an explosion. It's like a 2-for-1 sale. It takes a little longer to create a second explosive device. Things like pressure cookers, like were used in the Boston Marathon bombing a few years ago. There was a secondary device there that didn't go off, I believe. So that saves some lives. And those were battlefield things that were used early on in Iraq and Afghanistan. Not that they're not used now, but those were so successful over there that terrorists brought those same techniques here, and that's just a reality of our lives. So part of making sure that scene is safe to enter is making sure if there's an improvised explosive device that the scene's been cleared of potential secondary devices. The best thing is to have your patients brought out to you to a triage area, and you can go from there. Let somebody who's trained in dealing with explosives go in and do those things. Standard precautions, as you can imagine, penetrating chest trauma can involve substantial amounts of blood. We need to protect ourselves from that blood. So things like face shields, goggles, not just eyeglasses like these things. You need side shields, you need protection so that you don't get oversplash or undersplash coming into your eyes. Don't want to nail those mucous membranes and contract a bloodborne illness that way. Sorry about that. I thought that might be one of you texting me. Okay, it's important to identify the number of patients. Think back to that primary survey that we taught you in EMT class, that we've tried to expand on in this class. We've taught you to ask the question, is this my one and only one patient? Number of patients. We need help in identifying the number of patients. When does it become critical so that I need backup? I can only take care of one critical patient at a time. So if there's more than one, that exceeds my limitations. Well, not mine. I used to be able to handle 10 or 12, right? But no, you can only handle one at a time well. So we need to call in the troops if we have more than one critical patient, or if we have a critical patient, we need help. Try to determine the mechanism of injury. General impression, are they FTD? Are they thickened to die? Are they not thickened to die? If they're thickened to die, then we're into that platinum 10 minutes. We need 10 minutes or less on the scene. They need a surgeon to take care of them. They need definitive care at a trauma center. If we have a long transport time, we're considering engaging helicopter service if available. And we need to assess our patient's entire body, anterior, posterior. We've got a little video on that in a few minutes. Things to look for: accessory muscle use in the neck during breathing, distended, engorged external jugular veins. I'm going to add there flat jugular veins. If engorged jugular veins indicate increased pressure in the chest that interferes with venous return to the right side of the heart, that then what do flat jugular veins indicate? That indicates that we have a patient who is hypovolemic. So, and in EMS, I have a couple of pictures on this in a minute, but we don't usually do a good job of assessing jugular venous distension. Properly assessing JVD requires putting your patient in a 45-degree semi-Fowler's position and assessing how engorged their external jugular veins are, starting from about the clavicular level. So what do we do in EMS? We're worried about gross changes. We're not doing a full nursing assessment of a patient in the hospital that takes 20 or 30 minutes. We're looking at right now. So if we see external jugular veins that are the size of our patient's pinky finger, or even middle finger, I've seen them as big as middle finger or thumb, that is distended. That is something that we need to be concerned about. Something's causing that. We need to find out what. Airway and breathing. Do they have a good airway? Do they need spinal immobilization while we're thinking about airway? Why would I throw that in right now? Our techniques for opening the airway differ if we have potential spinal injury and we're taking spinal precautions versus guy in the ditch with the stab wound to his chest. If we know he was stabbed in the ditch, let's change that to a parking lot. Empty parking lot at a bar at 1:30 a.m. and there Everybody went somewhere. Everybody's in the bathroom after this happens. You can't find anybody to tell you anything. But the guy who is shot or stabbed in the middle of the parking lot of a bar or on the dance floor of a bar, that we're probably not worried about spinal immobilization there. So we can use the head tilt chin lift method to open his airway versus the jaw thrust. Jaw thrust is a little harder than they make it look in the videos, I always thought. We need to get their clothing out of the way. We can't inspect the anterior and posterior chest if there's clothing in the way. You'll notice in all the pictures and videos that I have later, you're looking at a naked chest. Palpate the patient's neck for tracheal deviation. That doesn't take long. Is that trachea, does it appear to be midline? Look at the jugular veins while you're right there. Distended or flat? That's all we're worried about. And inspect the chest. How long does that take? Probably 2 seconds. When they're long enough, say 5, long enough for them to take a good breath so you can see if there's symmetric chest rise, and look at, does the chest look like a normal chest? I guess that's what they mean by contour and appearance. Does it look screwed up or does it not look screwed up? We could add that to our decision tree, I guess. Okay, we're going to look for signs of soft tissue injury. That soft tissue injury, as I mentioned earlier, that could be a big contusion to the chest that decreases tidal volume because it hurts to take a deep breath. So we know that we need to do something possibly to adjust minute volume by bag assisting that patient. Look for paradoxical motion of the chest wall. I've got a cool video on that in a minute. It's as dramatic as any you'll ever see, I think. Retractions. Do we have the intercostal muscles sucking in around the ribs, for want of a better way of saying it? Like I said, I'm from Borger. That's just what happens. We're feeling for subcutaneous air. We're going to feel for that in the neck. We're going to feel for that above the clavicles, below the clavicles, across the chest, and into the axillary area. I've felt subcu emphysema, all those places. It only takes a second to check for subcu air there. You don't want to miss it. It is a significant finding. Impaled objects, hopefully those are pretty obvious. Knives, tree branches, screwdrivers. It's only limited by your imagination. Ice picks. Ice pick's a rough one, but it doesn't make a great big hole on the inside. Sometimes it's enough. I ran a murder with, and the mechanism of injury was stabbing with an ice pick, and on autopsy, they counted upwards of 200 ice pick stabs. If you have something small to stab with, apparently you compensate that by stabbing repeatedly. I think somebody was pretty mad to do that. Okay. Other penetrating objects. Doesn't have to still be impaled. Could be a bullet hole. Bullet hole, you find an entrance, look for an exit, always. Could be somebody stabbed with a knife, pulled it out. I've seen somebody in an unrestrained patient in a rollover without a gear shift knob on the stick shift, and several major penetrating injuries from that gear shift sticking in and out. Those make some nasty tears. I don't have pictures of that. I wish I did. Assess ventilation and oxygenation. So how are we going to do that in this primary survey? We're going to look to see if our patient is cyanotic, and we're going to look to make sure they appear to be moving a sufficient amount of air. Okay. Right away, we're not going to wait to do this. Someone with chest trauma, get an on-rebreather on them at 15 liters per minute. If they don't have head trauma and their level of consciousness is decreased, pop an MPA in so that you know you have a good patent airway. And we're going to watch for signs of an impending pneumothorax. Tension pneumo. We'll talk more about that in a minute. Palpate for point tenderness, bony instability, crepitus, sub-Q emphysema. It does what's like Rice Krispies. That's the old go-to for that. It really does feel like having a thin piece of plastic over Rice Krispies and pushing down on that and feeling that pop. That's the closest I can come. So you'll know it when you find it. You can't miss it. Look for edema. Percuss. We don't do that in many places in pre-hospital medicine. It's really important when assessing the chest. The video of the doc doing the chest assessment on the stupid mannequin in a minute will show you how to do that. Explain what we're looking for. We're looking for a gross assessment, a gross difference. If it rings like you're hitting a drum when you put your finger down on the chest and hit it with two other fingers, if it rings like a drum, that's hyperresonant, that's air in the chest. If it goes thud, then that's fluid in the chest. Adventitious lung sounds. Do we hear crackles / rails? They're still rails in my mind. Do we hear rhonchi? Maybe we hear wheezing for some reason. Maybe they're having an asthma attack before they got shot, or hitting the chest with a ball bat. And confirmation of lung sounds, that's comparing side to side. Auscultate the apex, base, base, and when you roll them over to assess the back, I like to auscultate the back as well. Circulatory assessment, that's going to determine hemodynamic stability. Really, your number one circulatory assessment, I think, is your patient's level of consciousness. Are they alert and appropriate? Are they unconscious, unresponsive? Look at their skin color, look at capillary refill, palpate bilateral radial pulses, bilateral femoral pulses. We'll talk about injuries in a minute that can make a difference in what you find in those as far as whether they have equal radial pulses. Okay. That is an engorged jugular vein. That is engorged all the way up. That is a very significant finding. It could be that this patient is an old COPDer and that looks normal. Could be, anyway. Auscultate the heart. What are we listening for? Are we listening for leaky valves? Are we listening to see if there's an S3 gallop? Any of that stuff? No, we want to hear if they're loud and appear to be normal, or if they're muffled and abnormal. If they're muffled, you're dealing probably with pericardial tamponade, and the fluid between the pericardium and the myocardium is just acting as a muffler that's keeping that sound from resonating when you listen. How do you know what normal heart sounds look like? You're not going to know what they look like. How do you know what they sound like? We have an extra class member down there. He's a cutie. Hi there. How do you know what muffled heart sounds sound like when you auscultate them? You listen to lots of non-muffled ones. So you start by listening to yourself. You listen to your little boy. You listen to your husband or wife. You listen to anybody who'll let you listen. And then as you start doing clinical, listen to the heart sounds of all the patients you encounter, not because we're cardiologists and we're going to find all the amazing heart murmurs and stuff. that a cardiologist and my wife can find. My wife is amazing with heart sounds. Don't tell her I said that. She'll think I like her. You can laugh. That was pretty funny. Greta, there's another German Shepherd over here. I like this. This is better than normal class in that way. I prefer to see you and hear you, though. Okay. Don't waste time on the scene trying to get a complete sample history and complete physical. We're going to do a rapid trauma right after the primary or as part of the primary, whichever way you like to do it. Just make sure rapid trauma gets done. You're experienced enough now to have personal preferences. You're not just regurgitating what we lay down in front of you. If you can get a history, that's great. If you can't, you can't. Don't jack around on the scene waiting to do that. Don't spend time on the scene. I've seen people do this before who were partners, and it was the subject of a little bit of disagreement between my partner and me. They want to stay on the scene and play doctor. I don't mean in the bad kind of way. They want to stay there and do this detailed assessment like a doctor would in the ER. These days, a doctor in the ER is going to do a rapid trauma according to advanced trauma life support guidelines. We need to be doing a rapid trauma according to PHTLS, which is also the same standard as your book. So get that rapid trauma done, looking for those life threats, and then we need to get on the road to do everything else. If you can, get one good solid set of vital signs, your baseline set on scene. Hopefully you have enough hands to accomplish all of this pretty much simultaneously. You get oxygen on my patient. You give me a good set of vital signs, and then I'm on with my assessment. You hold C-spine. If you don't know people's names, point to them and make sure they understand your direction. That is called being a team lead. Priorities, ABCs. Find them, fix them. Don't move on till they're fixed. All right. Any sign of poor perfusion or inadequate breathing. This is an emergent transport, and we're getting on the road to deal with this. Life-threatening chest injuries. You have a laundry list over there. Airway obstruction. You can read them. I don't need to read all those to you. We're going to go through them anyway. So we're going to blast on past that. History taking. And depending, if your patient, I've had some people with serious chest trauma who were still conscious and alert and could give me a relevant history. Are they allergic to meds? Do they have a cardiac history? Those kinds of things. Medications they take. A medication that could be really important to know about would be a patient who's on beta blockers. Patient on beta blockers is going to go from not being in shock to decompensated shock, just like snapping your fingers. They can't compensate. Their sympathetic nervous system is impaired because that beta blocker is blocking at least partially those beta 1 and beta 2 effects of the adrenaline that their body's being slammed with. And so what else does that entail? The heart rate doesn't increase sufficiently. Respiratory rate doesn't increase sufficiently. So that's a major problem when you have a patient who is becoming shocky. Get a sample history if you can while we're rolling down the road. Questions about the mechanism of injury, things that appear obvious to you that are related to the trauma. How fast were you going when you lost control of your car and rolled it 5 times? If they're still conscious, they can tell you that, hopefully. Maybe they're not willing to. That's an important thing to say. I'm not the police. I'm not going to write you a ticket. I'm not worried about that. I just need to know how to take care of you. If other things to consider with mechanism of injury, is there another occupant in the same passenger compartment who was killed in the accident? That patient is automatically a critical patient. Different amounts of intrusion into the patient compartment, rollovers, rotational trauma or rotational mechanism injury. Say somebody slides into a light pole at a high rate of speed and it hits the right rear quarter panel of their vehicle, and then they just spin out of control across the field. Those shear forces can do things like cause aortic shear, that kind of stuff. Good head to toe physical assessment, get that good set of vital signs, monitoring equipment that can be beneficial. So what are we talking about? End-tidal CO2, SpO2, cardiac monitor. So as we move into the fall semester and you take cardiology and you learn about cardiac monitoring, that will mean more to you. I'm not going to spend time on it now. I will show you one thing later because I don't remember if Paul includes this particular EKG finding in his cardiac course, and it's really obvious what I'll show you. So that's the monitoring equipment that we're talking about. And let's see if this video will show. Come on, launch. Oh, wait. Hold on. Could you see that video when I started it at all? No?
No.
Oh, that's going to be the pits if I can't. Okay, let's see. No. We didn't want to do that. Can you see? Can you hear it now? See it? Yes? No?
I can see it, but I can't hear it.
Crap. Oh, if these don't work, it's just going to suck. Let's see. Pause the recording. Now let's try. Now?
No, still can't hear it.
Dadgummit. Okay. Okay, watch what he does, and I will give a comment as we go. Wait, let me mute my sound of him. Okay, this
If
is
you want us to watch it, is there a way that you could share it to our group me thing and we can watch it then?
I can
In
try
addition
to.
to?
Let me let him run through this assessment. He is a medical doctor. I'm not. But let's watch what he does. It's exactly what we do. We paddle our hands in the air like that, like we're a dog swimming. What is he doing? He's palpating to see if the chest wall's intact. I always like to pause right there at the costal arch on each side and see if I feel symmetric chest rise. Then I don't have to guess. I'm not pushing down hard enough to interfere. He's palpating right now for subcutaneous air, and I would add that knife edge to the chest, right knife edge to the sternum to see if that sternum is intact. That is a major finding if you find a fractured sternum. He is right now telling you where to auscultate for breath sounds. Apex, right there below the clavicle on each side. base over. I always just went right lateral to nipple line. That's a good place to assess the lung sounds in the base. He's percussing. We've all felt the doctor do that to us. We've all seen the doctor do it to somebody else. We say that's too fancy for pre-hospital medicine. I don't. Some say too fancy for pre-hospital medicine. Precise term for that's horse crap. It is very important when we're assessing a chest, where if we don't do that, we miss out on some important information. Do we feel that resonance so that we know there's free air in that chest, as with a pneumothorax, or does it thud when we hit it because there's blood present? Okay, now let me get out of this somehow. Share something else. Okay. Zoom sharing. We're still recording. Okay. And if we find isolated chest trauma, there's no other trauma to our patient, we can do a focused assessment of the area affected. Watch for other things to develop with our patient, but we're not having to do that full head to toe exam every time. We can be more focused. What are we looking for with the skin? Ecchymosis, other trauma, major lacerations, identify wounds, control the bleeding, find them, fix them, move on. Okay. And then consider the underlying systems. What in the heck does that mean? If I have somebody who is busted in the chest with a baseball bat right at the left nipple, I'm concerned with what just happened to the heart and possibly the base of the base of the left lung. Okay, now crud. How long have we been going? Y'all need a break? Already took one. Yeah, everybody disappeared. Click the proper button. All right, here we go. Secondary assessment. Full body scan, inspect for deformities, palpate for tenderness, check for lacerations and swelling. If you haven't seen all this stuff in patients yet, when you do your clinical this summer, whether that's at the beginning of the summer or later in the summer, you will see those things. You will see lacerations and swelling in different areas. You know what normal looks like. If it doesn't look normal, it's abnormal. You don't even have to be from Border to figure that out, because that'd just be Robin and me, and everybody else would be in trouble. So we make it easy.
Jasmine's from Border.
Who is? Jasmine
Jasmine.
is? Well, why didn't she tell me that? We're taking over. All right. And reassessment, you know how to reassess. Get a new set of vital signs every time, every 5 minutes on critical patients, every 10 to 15 on non-critical. The more you assess your patient, the more you trend those vitals, the better idea that you have of how they're doing. And something I think that gets left out on reassessment and lost in the shuffle, maybe, if you have a major change in your patient's condition, start over with ABCs, work through the relevant portions of that primary, go back through secondary and figure out what has reared its ugly head on your patient. So oxygenation, skin color, level of consciousness, capillary refill, SpO2, end-tidal CO2, that's all going to give you a good picture of what's going on with your patient as far as oxygenation, Circulation goes hand in hand with that. If there's no circulation, there's no oxygenation unless we're providing it. Breath sounds, when you reassess those breath sounds, or if there's a change in your patient's condition. What are we looking for? One thing we're considering is possible development of extending a simple pneumo into a significant pneumo. And then what are we watching for from there? We're trying to make sure that we keep an eye on things to see if our patient starts to develop a tension pneumo. A question on when we get out the sharp objects and start poking holes in chest, otherwise known as needle decompression or pleural decompression. As soon as that simple pneumo starts to go tension, that's when we decompress. We don't decompress a simple pneumo in our world. So how do we know that when that change happens? We'll talk more about it in a minute. I'll leave you hanging. That's like I could be a radio host, except for nobody would listen because this is horrible listening to me. I hate listening to myself. I hope it's not as miserable for you.
Not that bad.
Any pneumo is going to be considered an unstable patient. Why is that? We're not shooting x-rays in the field so that we can see if there's a really minor pneumo that's going to resolve on its own. We're finding significant pneumos where we find that major resonance in the chest when we percuss it, where we see asymmetric chest rise, we auscultate and there's diminished breath sounds on one side. Those are a big deal. You couple that with signs of poor perfusion. Now in our minds, since we can't x-ray it, we're going to consider that to be a tension pneumo. We have a pneumothorax with signs of inadequate circulation. We have a tension pneumo, and we're going to pop a needle in something, hopefully not ourselves. Don't hang around on scene. We need to be doing this stuff on the road. Practice. When you do your ambulance clinicals this summer, listen to a lot of breath sounds rolling down the road. Don't just go there to get skills. Pick up assessment skills also, not just poking needles in veins. We need to be auscultating a lot of breath sounds going down the road so we understand how hard it is, but so that we know what we're doing when we're listening to these patients during reassessment. Make sure they still have a good patent airway. So what do we do if our patient's airway is compromised? If they'll tolerate an OPA, we put an OPA in. If not, then we're going to put an NPA in unless they have signs of unstable facial fractures or possibly have a basilar skull fracture. That's what you call that thing. Okay. And expeditious transport will add safely to that. And you may have a partner who's driving who is excitable and they want to fly to the hospital. And I always got pretty ticked when somebody threw me in the back of an ambulance when I was trying to take care of a patient, and things could get confrontational afterward, but I yelled things like slow down, and sometimes there were expletives involved if I had an unconscious patient and no family members. But there's no recording of it. We can't prove that ever happened. Okay, we've talked about this. Nasal airways, like we said, signs of facial fractures. It's a relative contraindication for a nasopharyngeal airway. Yeah, I should stop there. Okay. Endotracheal intubation versus nasal intubation. If you have major trauma to the neck and the chest, then we may be doing a surgical crite. I've done it on dogs and pigs and kitty cats and mannequins. I never had to cut a patient's throat. Just they were never that unlucky, I guess. I'm not a bad surgeon. Okay, ensure oxygenation and ventilation. How do we do that? Positive pressure ventilation, needling the chest so that we help deal with that shunting that may impair respiration in the alveoli, and stay on top of assessing that circulatory system. Your best friend here is going to be waveform capnography. With waveform capnography, you can see a change in tidal volume. You can see airway obstruction. You're taking a whole class in that right now. You could probably teach me. And the big thing is you can watch that end tidal CO2, see if it stays in range of 35 to 45 millimeters mercury. Pharmacologic agents, sedative for you. No, we don't do that. Okay. Medications for airway management. If we need to RSI these patients, RSI them so that we can manage their airway, we can manage their ventilation, and then pain management. Morphine sulfate, that used to be the big go-to for pre-hospital analgesia, and morphine has a tendency to drop the blood pressure in a trauma patient. So we always had to be really careful with that if we used it at all. Fentanyl doesn't seem to be as bad about that. Dosage of fentanyl, 1 microgram per kilogram IV push in adult patients. And then things like ketamine have shown some real promise. Ketamine and fentanyl, you should be able to RSI someone. Then you're not using a depolarizing agent. You sedate them, and you have an induction agent, and you can get them intubated. You can continue to use ketamine to knock them down so that you can manage their airway. Seems to work really well. Yes.
For the Untitled, do you know, or I need to ask Paul about the waveform that you would see on the monitor if they had a tension pneumo?
If I were you, I would Google it and find it. If I can find it, I'll post some video links. I'll post the video links to all of this in content. And I have a tab called videos under content, okay, and I'll post all of that there. Okay. But you're going to see a decreased tidal volume. It's not going to differentiate which side you have a pneumo or where you have a tension pneumo. But what you're going to see as a pneumo progresses is the tidal volume goes down. So that amplitude of inspiration changes, it decreases. So that should be what you see. But I'll find something good for you and get that posted. Let me make a note. You can watch me write for a second. If I don't write it down, it won't happen. Okay, it's on my magic list. It has a good chance of happening now if I can find one. Okay. If not, that may end up being a Dr. Morgan question, because I guarantee you he's seen a lot of them. I'm also taking online flight paramedic class right now. I might be able to find it there. Anyway, I'll get it for you one way or another. And then clinical state of our patient. Are they improving? Is their condition getting worse with the analgesia? And we have to be, well, anyway, we'll leave that for next fall when we throw quite a bit of pharmacology into the mix of this. The dosage on morphine, if your local protocol happened to be morphine and not fentanyl, which I think is more and more unlikely all the time, but the dosage on morphine is 2 to 10 milligrams IV push in adults. I don't expect you to remember that, but you've heard it once now. Okay, non-pharmaceutical splint injuries, put cold packs. If you put a cold pack on that giant contusion on somebody's chest that's causing them to breathe more shallowly, that knocks down some of that pain and inflammation, and it will should improve that tidal volume and minute volume. Don't forget good basic life support when you're operating at the advanced level. It takes both. And transport to the appropriate facility. You're not going to take an adult trauma to a podiatrist office. You're not going to take an adult penetrating chest trauma patient to a pediatric hospital or an oncology hospital. And then the golden period, formerly known as the golden hour, our trauma patients do considerably better if they reach definitive care, which would be that trauma center within an hour of the occurrence of the trauma. And if we can establish the time that the trauma occurred, that's going to come into play in whether we can use something like TXA that I'll talk about in a little bit. Okay, flail chest, 2 or more contiguous ribs fractured in 2 or more places. Flail sternum, much more severe. Break that sternum into 3 or more pieces, and that's pain-wise and integrity of the chest as a whole. That's a major change that's going to really impair your patient's tidal volume. And the pressure that it takes to fracture a sternum or cause a flail chest is going to cause or may cause significant damage to the organs in the thoracic cavity. Palpate the rib cage for fractures. Paradoxical movement is a fairly late finding with the flail chest. You have, anyway, as the response to the trauma progresses, and you have more inflammation and more compromised circulation to the intercostal muscles, and then you start to see that paradoxical motion. I'm going to show you in a second what it looks like. All right, I'm not going to do it to myself or my dog. My son's in the next room. We'll do it to him. How do we manage it? Positive pressure, ventilation, and then PEEP. PEEP is really important here. With flail chest, you have the chest wall compressing the parenchyma of the lung, which causes really a mechanical atelectasis. There is a major portion of the lung that can't participate in ventilation or respiration. So that has a big negative impact on our patient. We have to reinflate everything every time we ventilate that patient. With PEEP, it's going to help hold that back pressure, help keep things open, decrease atelectasis, and increase respiration. Okay, possibly a pulmonary contusion to go along with that. Okay. If nothing else, pain's going to decrease tidal volume. Going to palpate crepitus, tenderness. You may find sub-Q emphysema. and could hear diminished breath sounds. Okay, let's see what's not obvious here. Hypoxia, skin color, level of consciousness, SpO2, hypercarbia. How are we going to assess that? End-tidal CO2. End-tidal CO2 is the standard. You should have very few ALS ambulances out there without end-tidal CO2. It's especially at the paramedic level more than the intermediate level. That is an integrated part of almost all cardiac monitors that are capable of doing 12 leads. It does cost more. I think it adds a couple of grand to the price of the monitor, but it is the standard of care. And then pain, let's watch paradoxical motion here. I guess you won't be able to hear it, but I will post these videos in the video, under the video tab in content. But let's hopefully watch.
Buddy,
Oh, sorry, hold on just a second. Let me pause this.
maybe if you try taking off your headphones, that maybe we can hear it too.
Oh, yeah. I bet.
Melissa, you're so smart.
We'll listen to Dr. Bean just to hear if that. Did that make any difference?
No.
Okay. Well, I'll get those videos uploaded for you, and make sure you go watch them. There, I think it will really help you with your patient assessment.
Probably one thing that you can do is whenever you do post this lecture to your YouTube channel, you can link the videos that you're pertaining to in the description below.
Yeah, cool. Thank you.
And then we can just click those and watch them.
Good point, Will. I'll do it both places. As embarrassing as it might be, I'm gonna throw all this stuff out there on YouTube, and people can Google it and hear what an idiot I am, but they might pick up something that'll help them. Okay, now I have to get back to here. How do I unsee this? Go away. Nope, that wasn't it. Oh, what the heck? No, 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 no. Okay, sorry about I just lost everything. Hold on. Okay, let's go back to screen sharing. All right, can you see the PowerPoint again? This is Welcome to Death by PowerPoint 1455. All right. Flail chest, it may be significant enough, like in that video that we just saw, that we need to consider RSIing this patient so that we can take over and manage that with sufficient positive pressure ventilation. Our goal again is going to be SpO2 of 95 with supplemental oxygen and positive pressure ventilations. We also have to be careful if we suspect a pneumo with positive pressure ventilation, because we can extend the size of that pneumo and cause a tension pneumo. We don't want to be the cause of a tension pneumo, but we're never going to withhold oxygen and tidal volume and minute volume from our patients. So if your patient needs to be bagged, bag them. And if they need to be decompressed because you bagged them, decompress them. You get fun in two places. You get to RSI them, and you get to stab angiocasts in their chest. So good time was had by all, I guess. Okay, that's a rib fracture. They hurt. Usually people self-splint those things. they hold their arm across the area and they take shallow breaths. Those shallow breaths, because they decrease their own tidal volume, that causes atelectasis, which decreases perfusion. So, and this is a killer in old people like me, maybe even older than me, if you can imagine somebody being that old. Pneumonia. They fall, fracture ribs, and get a secondary pneumonia from that, and they die from it. That's exactly the progression of pathophysiology with my mother-in-law. My brother-in-law called me at about midnight one night, told me she fell and she had fractured ribs. She was 93 years old then. I didn't say this to anybody, but in my mind, I thought this is the beginning of the end. And she made it about 5 weeks after that. Not at all what I wanted. I just have seen it too much. I know that's the normal progression. Palpate for sub-Q emphysema. That's important. Remember that rib may break off and puncture the parenchyma of the lung, or protrude just enough in to cause a pneumothorax. So, okay, keep rolling. This talks about what you might find with fractured ribs in different areas. The more proximal it is, or the more caudal toward the head, that caudal, the more caudal the fracture, that would be ribs 4 through 9, the more likely you are to see trauma within the chest. When you get to the inferior rib cage down there after you hit the costal arch, then we're going to be looking at intra-abdominal injuries. Your biggies there are going to be a liver laceration. So that would be on the right side, down in that inferior margin of the ribs, over the top of the liver, and then on the left, in that inferior margin of the ribs, that's going to be your spleen, not yours, your patient's spleen. Hopefully this is never you, even though I say that all the time, and I don't know why I do that. All right. Patients report with rib fractures, pleuritic chest pain. What on earth is that? It hurts to take a deep breath, so they don't. Pleuritic chest pain is pain in the chest when taking a deep breath. That's whether it's a trauma, whether you're dealing with a trauma patient or a medical patient. Mild dyspnea, all the way up to moderate to severe dyspnea. Dyspnea of any kind, I guess we covered it all, right? Okay, physical exam, from crepitus to contusions, sub-Q emphysema, anything in between. And we manage it by managing ABCs. Even if their O2 sat's holding good at 94, 95%, throw a nasal cannula on them at 2 or 4 liters per minute. That way, with that decreased tidal volume they're going to have, you have increased the availability of oxygen in the alveoli. It's good old Henry's Law that we'll talk about here in a few weeks. That just means if you increase the concentration of a gas over a surface, then you have more of that gas available. So the surface in this case would be over the hemoglobin. So you have more oxygen molecules sitting there above the hemoglobin, then there's a better chance of hemoglobin and oxygen combining so that we better perfuse our patients. So that is an application of Henry's Law that we'll talk about in environmental emergencies when we get into all the dive emergencies. Gently splint the chest wall. Really the best thing you can do is maybe give them a pillow and they can hold that pillow and splint it themselves. You don't want to get aggressive and wrap anything around and around the chest, like with an elastic wrap, in my opinion, because you don't want to impair that tidal volume. And if we squeeze their chest down and they have to fight against it, they might not, and we may take a mild to moderate problem and make it a severe problem, and we sure don't want to do that. Let them splint it themselves, and at the paramedic level, pop a line in, throw a mic per kilogram of fentanyl in there, and they should feel a lot better. Sternal fractures takes a major impact to fracture a sternum. We need to be worried about myocardial contusions, pericardial tamponade, rupture of the great vessels, maybe even throw a bilateral pneumothoraces from the get-go in there, so we don't just have tension pneumo taking place. We have a pneumo on both sides progressing in our patient. That does happen. You can find a pneumo on both sides without having a tension pneumo, and you have some major trauma to your patient at that point. It's not uncommon to get a multi-systems trauma patient to the hospital and come back a little bit later and find out, because you always go back and check to see how that patient's doing. You go, hope you get another call so you can go back, poke your head in the trauma room, and you look in to see that your patient has 2 chest tubes, they're on the ventilator, and you think, oh my God, what did I miss? That just could be they have 2 pneumos that are developing and progressing, and maybe it didn't progress to the point that you found it pre-hospitally. That doesn't mean that you failed. As long as you did your job and did it well, things progress, things develop. Trauma is not, it's a dynamic situation, not a static situation. Tenderness. How do we find that? Remember back in that rapid trauma, do that knife edge hand to the sternum. Do you feel crepitus? Is there a segment of that that's floating around when you push down? If you feel crepitus, or you feel a piece of that sternum start to displace when you do that knife edge hand, stop. Don't push anymore. We don't want to poke holes in things with sharp bones. We need to apply enough pressure so that we can fully assess, though. Get an EKG. If we have a myocardial contusion, or if our patient has pericardial tamponade, then we can definitely see some EKG rhythm changes. Supportive care, ABCs, manage any other injuries, consider analgesics. And again, that's probably these days fentanyl at a mic per kilo, IV push, or morphine sulfate 2 to 10 milligrams IV. Morphine sometimes will nauseate a patient, can also sedate them so that you need to bag them. That fentanyl can also, I think morphine has more of a tendency to do that, and morphine has more of a tendency to drop the blood pressure. More on that next fall, but that will give you a little intro a couple of different times here. Clavicle fractures, really common in kiddos, not as common in adults. This is one of those injuries that your patient is going to splint it themselves. They're going to be holding their arm like this, and they are not going to want to let go. They're not going to want to let you do anything. You can help them out. You can just put a sling, tie a sling, the one where you just loop it around the wrist like that, and take it up around the neck, and then sit them in an upright position. And if you don't suspect spinal trauma, and that's going to let that hang there, it's going to provide natural traction. and let them splint that with their other arm, or use a cravat around the chest just to snug it up so their arm doesn't bounce around going down the road. That's how we treat that. I don't have a good picture of somebody with a fractured clavicle. They're pretty obvious when they happen. Simple pneumothorax, you know what that is. This is air starting to occupy. Oh, you can't see that pointer. How do I make that work? Tools. Nope, that ain't it.
We can see your mouse.
You can see it? Oh, okay. All right. So that is air in the chest, that dark area in there. Okay, that's air. This is the affected side. With x-rays, what are we doing? Number one, we're not reading them pre-hospitally, but if you get a hold of an x-ray, compare side to side and see what you see. That's we don't get that much more complicated than that. I think I have some better x-rays in a minute, but that's what you're looking for. All right, that mild dyspnea, pleuritic chest pain. That could be anything, right? It could be a fractured rib, could be a pneumo. And if you start finding diminished or unequal breath sounds and that hyperresonance, you're getting a larger pneumo. Just in our world, it's pretty significant pneumo before we find it. That doesn't mean they're automatically going to get a chest tube at the hospital. And if it's a small, simple pneumo, pre-hospitally, we're not going to go popping a needle in somebody's chest. We'll talk about when to do that in a second. Okay. Maintain the ABCs, get high concentration O2 on them, judicious use of positive pressure ventilation. Have to be really careful with that tidal volume. Probably you can, an adult patient, 350 to 500 cc's of tidal volume is a good tidal volume for an adult. So you, in that, most ambu bags, or well, I guess ambu's a brand, but most bags hold 1 liter to 1.5 liters. That PD bag is probably just about right to bag a normal size adult. It probably wouldn't work for me. You need a horse ventilation device for my big old goofy butt. Rapid recognition and management. The big thing for a simple pneumo, we have to monitor it and watch for the possibility of it becoming a tension pneumo. Open pneumo, that's when we have something that penetrates into the thoracic space, penetrating chest trauma. Once you have an opening in the chest that's equal to or larger than the glottic opening of your patient, which is roughly the size of their pinky finger, not hard and fast rule, but that's rough size, then you have a good chance of developing a sucking chest wound. Yeah, they all suck, but the ones that you hear air sucking into the chest and we need to immediately intervene and stop that. That's physiology.
Once you put that on, are you able to, if you have to like use a decompression needle, are you able to still do that even though they have something currently sticking out of them?
If you can see, if they have an impaled object that's still there, we need to seal around that the best we can, and then you should still be able to decompress them. You may have to decompress them more oftenly if they're still getting air in their chest, as decompression's not one and done. We decompress them as many times as we need to. We can make them look like a porcupine if we have to. I guess on the inside with the needle sticking through. I have a picture of that in a minute too. All right, there's what's happening. Sucking chest wound. Oh, man, it was the next slide. I could have read it instead of telling it. All right. Consider the fact that pulmonary vasculature could be involved. Then they're going to develop a hemopneumothorax. They have penetrating trauma through the chest wall and into the lung itself. So you have bleeding in the body of the lung. That's going to occupy space with fluid. And then you have pneumothorax developing also. So you get a hemopneumo then. It's just a little old stab wound there, looks like. Kind of bubbles, yeah. Kind of has kind of pinkish colored blood. It can have just blood running out of it from bleeding, but the bubbles are usually kind of pinkish colored and kind of frothy. You can find subcutaneous emphysema around it, and then maybe extending on up. With this one, you might find sub-Q emphysema extending up into the axillary area. You may even find it spreading up the chest like that. There's a bullet wound. You can see the right around there. That's caused from the barrel of the gun. This was a point blank shot. There's the gun wound in the center. I believe this is a post-mortem photograph. And then you have, this is just bleeding just down through the cutaneous tissue that caused that color. Now, it may not be post-mortem, still has electrodes, and it could have missed the heart, but I'm worried about the aortic arch. If the heart is right here, then the aortic arch is going to come around like that. It's amazing what a gunshot can miss, though. So that's
not to mention if there's any sort of cavitation at all, that could easily rupture vessels and the heart right then and there.
Great point, Jake. That is absolutely right, Tanner. I almost called you Jacob. Where'd that come from? That's exactly right, Tanner. Well, yeah, okay, I know why I did that. That's exactly right. And so you have cavitation. Oh man, let's see. We don't know how big this person is. We don't know how big that nipple is, but I mean, that could be anything, depending on the size of the person, could be anything from a 9mm to a 45, maybe. I don't know.
Even still, statistically, gunshot wounds, especially with handguns, even with multiple hits, about 80% of gunshot wound victims actually survive from handguns.
Yeah, that would be consistent with my experience in the field. I think that's a good point. This one I'm concerned about because of the location of the gunshot. Trajectory is everything. That looks like a straight through and through, but we don't have an exit wound. And when I found this picture, I couldn't find an exit wound. That's a shotgun to the chest, or at least that's what the caption said.
Yeah, that looks like a bunch of birds shot, and from pretty close distance as well. That's probably easily within 10 to 15 yards at least.
Yeah,
bird shot tends to not spread very much at close distances, at least.
And you will see it like this center part here that just looks like shredded hamburger meat. If the shotgun's close enough, just the muzzle blast, the gases can cause an injury that looks like that. And I've even seen the wadding that holds the shot in the shotgun shell actually be embedded in a patient. That's a pretty significant wound. Up here, see the clavicle right here? that subclavian vein nestles right up there by that clavicle. So I'd be really concerned about subclavian vein or artery being involved, and then maybe extending down here into the axillary region. So there's this, and then there's, I mean, we nailed a lung for sure up here because the apex of that left lung comes up at least that far. So that is a significant amount of trauma to that patient. The patient's skin color to me looks like the patient's probably still alive, but it's hard to tell. Okay, let's see. Assessment is the same. Okay, there is a chest seal. These commercial chest seals, a lot of them have a one-way valve that you put right over the penetrating trauma. If you need to make your own, okay, for just to do something like right now rapid, when we first make patient contact, throw a gloved hand over that, have somebody hand you an EKG electrode, stick the EKG electrode over the top of that, move on with your primary assessment, get the high flow to go and get a good set of vitals, get them in the truck, and start bagging them, whatever we're going to need to do. And then we can move on to a chest seal, have somebody move on to a chest seal, or carefully take that package of Vaseline gauze. It's in that little 4x4 aluminum foil packet. Carefully open that, throw away the Vaseline gauze, flip that thing over, and put one side, well, only one side will go over it. Brilliant statement, buddy. Cover the wound with that sterile aluminum foil. It's real thick foil. Take 3 sides of that, and you have a chest seal and you have a flutter valve. So with positive pressure ventilation, hopefully that'll help move some of that air in the thoracic cavity out through that hole, and that will help keep that pneumothorax from progressing. You're also going to be concerned about the development of hemothorax. We can do something about a pneumo in the field with decompression, even with the finger thoracotomy that paramedics are doing a lot of places. You make an incision like you're going to put a chest tube in. You pop a pair of curved Kellys in that, curved hemostats in that, pop through the parietal pleura with stick your finger in there, open up the hole with your finger, throw a chest seal over it, you're off to the races. Their paramedics are doing that in Lubbock. It hadn't hit Amarillo yet.
Could you use like a tegaderm, like in their IV start kits?
That could work, sure. Tegaderm. You don't have the flutter valve capability then with the tegaderm. I hate tegaderms. They get stuck all to my fingers and stuff. Grab one of those VenaGuards. If you have those, throw a VenaGuard over it till you can get. You need a rapid seal to get you by for right now. Then you need some way to make that three-sided dressing with the Vaseline gauze or with that commercial chest seal. A lot of places just don't spend the money or don't have the money to buy the commercial chest seal. Know your equipment, know what it is, know how to use it. Supplement with non-rebreather mask at 15 liters per minute or positive pressure ventilation. Okay. Doesn't always become a tension pneumo, but there's a good chance of it. If we can treat it effectively early, then we're not going to progress to a tension pneumo, hopefully. Okay. That just demonstrates that air accumulating and compressing the the lung, and then that's starting to narrow that mediastinal space. That's where the heart sits, where the great vessels run. That starts to decrease that. That's why you start seeing distended neck veins. You start seeing signs of poor perfusion because you've dumped your preload. And you dump your preload, you dump the cardiac output. So these patients, when you start to compress the mediastinum, you're going to see a significant change in your patient. That's a little harder to see on the x-ray. This side of the heart should sit more over here. So there's a pretty good mediastinal shift. Let's see. And you start to have crimping of the great vessels. You can have, all right. Lose the ability to oxygenate blood, ability to eliminate CO2, and our patient starts to become acidotic, which is no bueno. Okay. I don't think we'll be able to, I wish I could figure out how to make, let's try this. No, let's don't. Okay, I will post that video also of assessing pulsus paradoxus. It's a good video. Pulsus paradoxus on inhalation. You have a 10 millimeter mercury, easy for you to say. On inspiration, your patient has 10 plus millimeter mercury drop in systolic pressure. Why is that? Let's get back up here. So we have the heart being compressed in the mediastinum. Our patient inhales, this lung inflates, and that compresses the heart more in the mediastinum, and that decreases the ejection fraction of the left ventricle. So stroke volume is lower, and because there's lower stroke volume, because of that compression, you have that drop in blood pressure on inspiration. Then your patient exhales, and there's more room in the mediastinum for ventricular refill. So that is pulsus paradoxicus. The video explains it better than I do, but that's why it's happening. Now, when you watch the video, maybe it'll help it make more sense. Things we see, remember I said that I like to put one hand on each side of the chest down around the costal arch. And that allows me to assess equal or unequal chest rise. Actually, the doctor I learned that from, if you've ever watched MASH, Dr. Blank used to be a doctor here in Amarillo at our ER, and Dr. Blank was a real MASH doctor in Korea. I learned a lot of things from him. I learned how to get yelled at. I learned how to move when things were thrown in a trauma room. I learned combinations of words that I didn't know existed, but also learned a lot of medicine from Dr. Blank. He retired from Amarillo to go to Albuquerque and make custom furniture for houses. He'd had enough of doctoring after 35 or 40 years. All right, let's see. Dysrhythmias, I'm going to show you one in a second. Could range from ventricular ectopy onto something pretty significant. I'll show you in a second. JVD, we already talked about. Narrowing pulse pressure. Narrowing pulse pressure is different than pulsus paradoxus. Narrowing pulse pressure is when it goes hand in hand with pulsus paradoxus, but systolic blood pressure decreases because your patient doesn't have complete ventricular refill therefore stroke volume goes down, and you're going to have a lower systolic blood pressure. Tracheal deviation is a late finding if you ever see it at all. Chances are you won't. Nothing against you. I don't mean that your eyes are incapable of seeing it. It's a late finding if it happens at all, and they're usually going to see it in the ER. We're not going to see it out in our world. Hopefully we manage our tension pneumo so that it doesn't happen. Okay. We decrease venous return to the heart, so we drop, that's overall blood pressure decreases because we decrease preload. Okay. This is the standard way of putting your patient in a semi-Fowler position and assessing JVD at 2 centimeters above the clavicle. You can do that if you have time. I'm looking to see if it looks like the jugular veins on that old lady earlier. Okay. Hypotension occurs late. They may have pleuritic chest pain. Anybody remember what that is? Pain on inspiration. And dyspnea goes with it. Okay. We're going to get after the high flow O2 right off the bat, inspect chest, cover the open wounds with that 3-sided dressing, like I said, and then move on to needle decompression. There's a great video, the best one I've seen. It's a military video on tension pneumos and the insertion of an angiocath for decompression. Okay. Here's a picture I found that kind of has the landmark superimposed over the chest. That's what we're shooting for right there. Mid-clavicular line, 1 second intercostal space. We go above the rib. Remember, under the rib is where the neurovascular bundle is. It tucks up under that inferior margin of the rib. And if we stick from underneath like that, we can go right through the intercostal artery, intercostal vein, and cause some significant bleeding. Or what would happen if we damaged that nerve that's tucked under there? We could paralyze an area of the chest which would compromise their tidal volume and compromise their minute volume, and in the end compromise our patient. Other place for pleural decompression, which is, there are quite a few studies showing that this is the superior approach, and I expect within the next 2 or 3 years to see a shift away from that anterior pleural decompression and go with mid-axillary line, 5th intercostal space, back where we started, where God intended it. Okay, this shows, this person's dead, by the way. This shows probably a 14 gauge angiocath, 3 1/4 or 3 1/2 inch. That's coming through the chest wall, passing through into that pleural space. That's where that thing has to be, where the tip of that catheter has to be for that to work. There are several studies out there that show that in a normal adult, even with a cardiothoracic surgeon doing the stick, that we need a 3 1/4 inch angiocath. There's one study that shows that only 20% of the time in that mid-clavicular approach do we get the tip of that angiocath into the pleural space. More often it stays up here in the just above that pleural cavity, and we don't get it in far enough. Or if it's a short one, 1 1/4 inches, 1 3/4 inches, it just sticks up here in this sub-Q fat. So we need a long angiocath, and studies show that it should be in the 5th intercostal space. However, your book, I'm telling you that for some real world medicine. For the book, for the exam, for National Registry, unless it changes, and if it does, I'll tell you, we go mid-clavicular line, 2nd intercostal space, and we go above the rib. Just good thing to do is just stick till you hit bone at the top of the rib that's below where you want your catheter to be. Walk up over the top of that rib and straight into the chest, and you're headed in the right place, and you haven't lacerated, at least haven't lacerated an intercostal artery or vein. There are also studies showing with that midclavicular stick, occasionally we're cannulating or sticking that needle, that stylet with the catheter on it, through some of the major vasculature in the thoracic cavity, which can be a problem. So we don't have those same complications with mid-axillary stick. That's why, based on studies I'm reading, I expect it to go back to 5th intercostal space, mid-axillary line. And I will put this video up there. Also, hemothorax, we have blood filling up that thoracic cavity. It could be blood filling up inside the lung. It could be blood around the lung. Takes a surgeon to fix that. How do we find it versus finding a pneumo? We have unequal breath sounds, and on percussion, we have the chest wall on percussion is dull to percussion. All right, let's see. More pictures. Massive hemo can be 1,500 milliliters or more in the chest. That poses 2 problems, right? We're starting to get into losing half the blood volume, maybe. A quarter to a third of the blood volume of our patient. If you'll remember from the 2nd lecture of the semester, body can compensate for a rapid 20% loss in total circulating volume. This would be more in most people than 20%. So we're going to have a patient who is in hemorrhagic shock, as well as having that lung capacity compromised because of blood occupying that pleural space, and we can't let that out. I've also seen them. Oh, go ahead.
The needle decompression, you didn't know that they had a hemothorax, and that blood came out. I mean, obviously that's a bad day. What would you do?
Now, if you're percussing it, if you percuss it, then you're not going to cause blood to come out. If you decompress and you get blood shooting out of it, pull the thing out and put and throw an EKG electrode over it. That's all. That's okay. And I have seen that. It's rare, and it freaks you out when it happens. But we didn't make them worse. If we pull it out right away and we cover it with, I would use an EKG electrode, and that's and as far as your book goes, it says we never decompress a hemothorax. But in the old days, we put chest tubes in pre-hospitally, and I've popped a chest tube in before and had blood gush out, and all you do then is just clamp that chest tube. So if you're ever a flight medic down the road and you're putting chest tubes in and blood starts shooting out, remember I told you to clamp the thing, and you're going to have a seal around the chest anyway, so you haven't made your patient worse.
Did you have to worry about, like in the hospital setting, that blood becoming necrotic to the lung?
They're going to get it out of it. They're going to go to surgery, and a thoracic surgeon is going to crack their chest and go in there and find the problem and fix it. So we're not going to have a long-term situation of blood sitting in the chest, because if you have a massive hemothorax like this, then you're going to have a surgeon's hands in there dealing with it. Is that an evasive enough answer? That's the best answer I have. It's okay. Obviously, you're going to have ventilatory insufficiency. You're going to have poor bag compliance. You're going to have poor bag compliance with a significant pneumo and with a tension pneumo also. Just hard to bag them. That if you have a simple pneumo and you're bagging your patient, let's jump around here. If you have a simple pneumo, you're bagging your patient and bag compliance gets really poor, that patient is moving toward a tension pneumo, and it's time to get ready to decompress, in my book anyway. Okay, hypovolemic shock, I already talked about it. We're going to wrap up hemothorax, and we're going to take a quick break so I can chop the video up a little bit. Everybody needs to get some blood flow back in their gluteus maximuses, or maximi, I guess you would say. Okay. What are we going to find to differentiate this from other injuries? Lack of tracheal deviation. They used to teach us that the trachea deviates away from a tension pneumo and toward a hemothorax. I don't know where that came from, because I can't find anything that says that anymore. That's not good medicine anymore. If you find a book that says that, put it on the shelf. It's a history book now. Possible hemoptysis, coughing up blood, right? Dullness of percussion, flat neck veins with hypovolemia, and with increased intrathoracic pressure, you can see distended neck veins. So those flat neck veins can become distended when the pressure gets high enough with a hemopneumo or with a massive hemothorax. Okay. Supportive care, rapid transport, high flow O2, positive pressure ventilation. Don't hesitate to RSI them and bag them depending on your protocols. These are sick patients. 2 18-gauge peripheral IVs. If you can get something bigger in, get something bigger in, because they're going to need to put pressure bags on blood products and rapidly infuse some blood products. Don't get carried away with your crystalloid fluid replenishment with hypovolemic patient. There is no hemoglobin in normal saline or lactated ringers, and you wash out what hemoglobin you have. You dilute it. I mean, you dilute what red blood cells you have, so you have less available hemoglobin for the oxygen to bind to. So you take a bad problem and make it worse. For hemorrhage, tranexamic acid, TXA, widely used in military medicine, widely used in flight medicine. It's emerging use. It has emerging use in ground EMS. I think it might even be in the new protocols at AMS. What TXA does, it's a medication that blocks the breakdown of blood clots. So it keeps fibrin, it takes out the amino acid needed to cause fibrin to become fibrinogen. Fibrinogen breaks down clots. So that's what it's for. The more closely it's administered to the traumatic event, the better your patient will do. Best results, super good results within the first hour. You cannot administer it after 3 hours from the time of the trauma. So that would be a contraindication of the medication. Another contraindication would be signs of a subarachnoid hemorrhage. So you have time, you have that time constraint, How do we give it? We take 1 gram and dilute it in 100 cc's of LR or normal saline and fuse it over 10 minutes. When we get them to the hospital, they're going to put 1 gram in, no, we put 1 gram and 10 cc's over 10 minutes. At the hospital, we're going to put 1 gram and 100 cc's and give it over 8 hours. And again, it has to be within that time window. That's not, right now TXA isn't on the National Registry, but I want you to be exposed to it a little bit. Okay, let's take a break there and we'll come back and pick up pulmonary contusion and finish this thing on out. So I'm going to pause the, there we go. Pulmonary contusion. What happens in pulmonary contusion? You have a bruise to the lung itself. You lose blood into the tissue of the lung. White blood cells go to try to deal with that damage, so you have localized edema. It's just like having a bruise anywhere else. You have that swelling. It's just this time it's on the lung itself. Surfactant is diluted because of that edema. What in the world? So why does that matter? Surfactant is diluted. Surfactant is what keeps the alveoli expanded, and when surfactant is diluted, then atelectasis occurs, or that alveolus collapses. It won't be all of them. You have some who stay at their natural size, some that are collapsed. When your patient inhales, and you have that pressure gradient move in, you're going to have really high pressure in the alveolus that has collapsed because of the lack of surfactant. So it's going to shunt that air to a larger alveolus that's not collapsed. So why does that matter? It decreases respiration, it decreases oxygenation of our patients, they become hypoxic, and then it just progresses from there. Okay, what do we find? They're hypoxic, they retain CO2, they are in respiratory distress, we're trying to fend off respiratory failure. If we have a sick, good news for us, let me back up, I guess. Usually you see pulmonary contusion develop and exacerbate after your patient's in the ER or maybe even in a critical care unit, rather than seeing that progress in the field. If you begin treating your patient in a time period proximate to the injury, we're probably not going to see evidence of a pulmonary contusion. But grandma fell last night and whacked her ribs on the coffee table and fractured some ribs. She doesn't have a flail segment, but she has fractured ribs and she has a pulmonary contusion. Her daughter comes by to check on her the next morning, finds her, calls us. We might find the pulmonary contusion then. So respiratory distress, dyspnea, tachypnea, trying to compensate for the decreased involvement of the decreased percentage of participation of the lung in ventilation and respiration, become agitated, restless, eventually become disoriented. Evidence of overlying injury would raise your index of suspicion of a pulmonary contusion. If they have a contusion to their chest wall, have tenderness crepitus, or if they have that flail segment, then they may have a pulmonary contusion. Auscultation, you can find those things. Just the things you would expect. crackles, rhonchi, maybe wheezes as that inflammation progresses, right? It narrows those airways down in the bronchioles and maybe even eventually up into the bronchi as that inflammation progresses up from the lung tissue, and you eventually end up with diminished breath sounds. Manage their airway. Caution when administering IV fluids. Small amounts of analgesics for pain. Cardiac tamponade, we know what it is. It's fluid in the sac around the heart, right? That's a pericardium. It is pretty much a potential space in a normal heart. You have pericardial fluid that is between the pericardial sac and the heart, and that's just there to decrease friction as the heart beats. If it didn't have that fluid, that slick fluid there, then it would start to eventually rub a hole in the pericardium. So as that fills up, compresses the heart, it impairs refill. So what determines the hemodynamic impact of this? Size of a pericardial perforation that results in hemorrhaging, which chamber of the heart is involved. If it's the left ventricle that's being compressed, then it will manifest itself. It can, similar to left heart failure. If it's the right side, if it's the right ventricle, then look for decreased right heart function, which would mean that we don't have, our preload is decreased, the blood that circulated out to the lungs is decreased, then left-sided heart function is decreased. So are we going to be able to tell which chamber is involved pre-hospitally? Probably not. In a medical situation, this comes about slowly. Trauma, it happens quickly. You usually have the heart muscle, the myocardium itself is bleeding. It depends on what vessels are involved as to how fast that fills up and how quickly the signs and symptoms of cardiac tamponade develop. Okay. As the atria and the vena cava are compressed, then preload delivery decreases, heart rate increases to compensate. Only 10 to 40%. In EMT class, we taught you about Beck's triad. And if your patient had cardiac tamponade, you would find Beck's triad. We lied to you. Only 10 to 40% of the time will patient present with Beck's triad. What is Beck's triad? Muffled heart tones, hypotension, jugular venous distension. You can have cardiac tamponade without having all three. Beck's triad is all three. So maybe that they find it at the hospital. We don't find it. Electrical alternans, I told you I'd show you an EKG in a minute and explain something. In that other 60 to 90% of patients with cardiac tamponade, there's a good chance in the EKG, ECG, same thing, that we're going to see electrical alternans or alternans, depends on what part of the country you're from. All I'm going to show you here, these big spikes are called R waves. That's when the ventricles contract. In our 12 lead, it's easiest to see if we look up here in 1, 2, or 3. Those are just different electrical views of the heart, depending on what the direction of travel of depolarization or electricity moving through the heart is. And you can see This is amplitude, how high up that big spike goes. This one is short, that one's tall. This one's short, that one's tall. This one's short, that one's tall. That is electrical alternans. That is highly indicative of cardiac tamponade. I've never have remembered to ask Paul if he includes that in his cardiology class, but I wanted you to at least see it somewhere so that in the back of your mind you think, oh, holy crap, I remember the old fat ball guy saying something about this. My patient has chest trauma. I throw the EKG on and boom, 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 boom. This long one here is the same as that short one there. This one, long one here, is the same as that short one. That one is this one down here on the bottom right. These are just different electrical views of the heart. I'm not teaching you cardiology, but I wanted to kind of tell you what was up there in front of you. But see, boom, 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 up and down, electrical alternans. Questions about that? You're going to know all about this thing right in front of you by the end of the fall semester, and you're going to be so proud of yourselves, and I'm going to be so proud of you, I might even cry. All right. So I don't cry now, we'll move right on through the rest of this cardiac tamponade and run out the rest of this lecture and call it a day. Okay, findings typical of shock. Weak or absent radial or peripheral pulses, radial pulses, brachial pulses, all your normal peripheral pulses. Patient's diaphoretic, dyspneic, cyanotic, altered mental status, tachycardia, tachypnea, agitation. Looks like shock to me. Okay. And that's just, you have this PowerPoint, you can go back and look at how to distinguish pericardial tamponade from tension pneumothorax. Okay, how do we treat it? That's important. Take care of the ABCs. That is most important. Ensure adequate O2. How do we do that? Sometimes we RSI them. Sometimes we just bag a system. In any event, we're going to give them O2 via non-rebreather mask. I would go ahead, get one IV in them. If you have time, get two. If they have significant enough trauma to cause cardiac tamponade, they may well have other internal injuries. Doesn't hurt to have two good patent IVs so that, and I'm not talking about running fluid wide open like we did in the old days. I'm talking about getting two lines, and if we have to administer a fluid bolus of 100 to 250 cc's to increase perfusion. Permissive hypotension, you may remember that from the second lecture of this course. We allow our patients to stay on the hypotensive side. We don't run crystalloids in to the point we get their blood pressure up. They may have something that's they're coagulating, they're decreasing bleeding on their own. If we pour the fluids to them, we wash that out and we increase bleeding. So we made our patients worse. We don't want to do that. Remember that the volume of fluid infused depends on respiratory status. We're going to stay on top of auscultating those breath sounds as we administer fluid. We can't suck it back out after we put it in. So we've got to stay on top of how much fluid we give. Fluid will be normal saline or LR. And in some places as paramedics, you will be administering whole blood or maybe packed red blood cells. Okay. In the old days, pre-hospitally, we were taught to fix this. We fixed it on dogs in a dog lab. Greta, close your ears. We learned how to attach an electrode, put one electrode on our patient's chest, and then with an alligator clip, put an electrode on a long needle with usually a 30 cc syringe, and you stick the needle in the chest. You aspirate the plunger, which means you pull back on the plunger, and when you get capture of a waveform on the EKG, that's when you advance it just a little bit and start sucking the blood out. That's called a pericardiocentesis. If bleeding has stopped or bleeding's controlled, a cardiothoracic surgeon is likely to cut what's called a pericardial window. They cut a hole in the pericardium, and that lets the fluid leak out. Eventually it heals, but you increase cardiac output. Myocardial contusion, bruise on the heart itself. Not a real common thing. It's usually a deceleration injury, the heart just slamming against the sternum. I guess if you were going backward when you impacted something, it could slam against the vertebra, the spine. That's what you call that thing, that long thing with all the vertebrae put together. That'd be a spine. It could slam against that if your patient's flying backward and they have that deceleration injury. And the local tissue starts to hemorrhage. You get edema, it damages cells within the myocardium. It causes funky EKG stuff. That would be ectopic activity. Reentry pathways, you'll learn about this in the fall. That's when the electrical impulse coming from the SA node, then down past the AV node, if you remember that from EMT class, it gets right past the AV node, and then where's a picture of the heart? Okay, it comes down like this, and it gets in a loop, and it just goes round and round and round, and that causes an extremely rapid heart rate. It's called reentry phenomenon, conduction through reentry pathways, and it can be absolutely a lethal dysrhythmia. That's paroxysmal atrial tachycardia or atrial tachycardia, and you're seeing heart rates of like 200, 300. And you don't get refill in the ventricle, so cardiac output goes in the crapper because there's not time for refill. So your preload goes out, your afterload goes out, cardiac output goes down, and patients die. Dysrhythmias, we're going to treat those, file this away in the back of your heads, not for advanced EMT, and I'm not going to put this on the exam. I'll weed out all those questions that pop up having to do with this when I prepare your next exam. But when you get to the paramedic level, we treat these funky EKG changes, otherwise known as ectopy. We treat that with the appropriate cardiac drugs. All right. They have retrosternal chest pain. What does that mean? Right behind the sternum. So a lot of textbooks even still say that our cardiac patients who are having angina have substernal chest pain. Incorrect anatomy. Substernal would be down in your epigastrum. Retrosternal chest pain is straight back behind the sternum. All right. We're moving on to advanced stuff now. We have to use the right terms. So retrosternal chest pain that's sharp, crackles on auscultation, could possibly progress to rhonchi. If left heart function goes down, because that's the left ventricle, is where the contusion is. It's going to cause, remembering how blood circulates, or remembering cardiopulmonary circulation, the right ventricle is going to send blood to the lungs for oxygenation. It comes back to the left atrium, then down to the left ventricle to be pumped out through the aorta. But if we have a contusion on the left ventricle, then that may cause blood to back up in the lungs, just like left heart failure. Then you're going to have wet lung sounds. You're going to have rhonchi. It will start with rails or crackles, same thing. Rails and crackles are the same thing. Then as we have more and more blood in the lungs, it actually, if you've ever seen an old coffee percolator that goes bloop, 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 that's kind of how rhonchi sound. Go out and Google these breath sounds and learn what they sound like so you know what they are when you find them. And then, as I said, abnormal EKG. Supportive care, fluid resuscitation, consult medical control for administering antidysrhythmic agents. The PowerPoint and the book contradict themselves. Your protocols may allow you to go ahead and just administer the antidysrhythmic. If you're unsure, always get a hold of medical control. Myocardial rupture. This would be almost universally lethal, I would think. We're not going to know that we have, well, we might have an idea we have this, but perforation, every part of the heart can be ruptured. It could be a rib that does this. It could be a bullet. It could be a knife. It could be a gear shift lever. It could be a piece of rebar. What else have I seen stuck through a chest? A big stick from a branch. That is a nasty thing. A piece of wood stuck through a chest. That's just the pits. And if it hits the heart, we're usually going to have a dead patient. Assessment, if they're not dead right there, DRT, or dead on scene. I prefer DRT, but that's not in your book. If they're not DRT, then acute pulmonary edema, signs of cardiac tamponade. Remember back to Beck's triad, or if we don't have Beck's triad, we might have that electrical alternans. Supportive care, rapid transport, super rapid transport. Commotio cordis, that's the kid throwing the baseball, and a line drive comes right back and hits him in the chest. It hits in, remember this for cardiology class, this will make more sense then. The second half of the T wave represents ventricular repolarization. This is all electrical. The second half of the T wave is ventricular repolarization, or the whole T wave is ventricular repolarization. The first half of it is the absolute refractory period. The ventricles cannot be stimulated and made to react in the absolute refractory period. During the relative refractory period, a blow to the chest can cause your patient, or an electrical shock in the relative refractory period could cause your patient to go into VFib or ventricular tachycardia. Either one, those are lethal dysrhythmias. Good news is it happened right in front of you. More good news is your patient was probably doing fine before that. We didn't have an old sick person who went into VFib, or somebody who's having a myocardial infarction and goes into VFib. We have somebody in this example who's playing baseball and got hit with a 130 mile an hour line drive right to the chest and drops on the spot in cardiopulmonary arrest. We start CPR right now and we treat it with electricity. We deliver that electricity one of two ways. We deliver it with an AED or with a defibrillator. And over 90% of those patients, if they're defibrillated within the first 2 minutes, will survive. You will be able to successfully defibrillate them, and they might not even want to go to the hospital with you. Probably will, but their coach or their parent will make them. Okay, it looks like any other cardiac arrest. So how do we distinguish that from any other cardiac arrest? Well, it's the mechanism of injury. They got drilled with something right in the chest. What else could it be? Could be a hockey puck. Could be hitting the chest with a baseball bat. Fall from height, I guess, maybe. All right. Traumatic aortic disruption, I kind of talked about that. You have usually a shearing force is your mechanism of injury, like from a major side impact in a motor vehicle collision, or a rollover, or a rotational mechanism of injury, like when a car is struck and spins around in a circle like that. Anything that's so that you have those shearing forces, it can tear the aorta. It can even completely transect the aorta. We call that dead. Can't fix that. Okay. So aorta ruptures at the point of attachment. It could be less significant. Let's say we have this is going to present itself as a traumatic MOI, but you see the same thing that you do with a aortic aneurysm in a medical situation, so that you usually have a tear of the strongest part of the aorta or any artery, which would be the tunica intima, that inside layer, and then you get a bulging effect in through that, whatever that weak place is in the aorta. You have drop in blood pressure. You can have, if it's distal, maybe our patient loses femoral pulses. They lose circulation to their legs, but they're perfusing the upper extremities. If it's up here in the proximal section that I'm kind of circling right now, you can have unequal blood pressures between each arm, unequal pulses. Your chest trauma patients or your rapid deceleration patients, really good idea to always, as part of your secondary, after you've dealt with life threats, let's get blood pressure in each arm and see if we have a difference in blood pressures. You may not have time to do that. You may be fighting the Grim Reaper and never get that far in your assessment of your patient, because that is part of the assessment, and that's fine. If you don't get that far, you're trying to keep them alive till you get them to the hospital so they can do something about the problem. So there's no shame there. You haven't malpracticed. You haven't fallen below the standard of care, but document why you didn't get in. Boing, boing, boing. I'm bouncing along. Why you didn't make it down the timeline into that full secondary assessment. Okay. Symptoms vary anywhere from that tearing pain. Remember back in the EMT class when we studied aortic aneurysms, we told you that had that sudden onset of a tearing pain, just felt like something was tearing my guts out or tearing a hole in my chest. And then they have quickly developed hypovolemic shock, dyspnea, altered mental state. If the tear from this is in the abdomen, you may find a pulsating mass in the abdomen. In a more slender person, You might even see that pulsating mass in the abdomen, or as you palpate the abdomen, you might find it then. Don't poke on it anymore after you find it. You don't want to rupture it. I have seen them in patients. I've felt them in patients. Hopefully I didn't miss one. Okay, let's see. We're knocking on the door of finishing this thing. It's a good thing because class is over in 10 minutes. Okay. Could have difficulty swallowing, could have an expiratory stridor, could be hoarse, could have difficulty swallowing. That's going to be if the injury is really high, or not up here. Your aorta isn't up there, more up here. Okay, can be that you don't see any signs of external trauma. You just have a pulseless apneic dead on the scene patient. Okay, things that would raise your index of suspicion of aortic disruption, multiple rib fractures, flail segment, sternal fracture, scapular fracture. That little flat bone is hard to fracture, and if you find that little sucker fractured, look for some major blunt force trauma to your patient. And if it's on the left side, you sure could have some aortic injury. Pericardial tamponade, hemothorax, pneumothorax, clavicle fracture. A lot of those all go with massive thoracic trauma. What do we do for it? Assess ABCs, gradual hydration, permissive hypotension is your friend here. We don't want to do anything that's going to raise the pressure enough that's going to cause that thing to completely rupture. So we've got to be careful. Do not, under any circumstances, use a vasopressor that can cause that weakened aorta to go ahead and rupture. And we need to get them to a trauma center like the second it happened, if not before. No, that wouldn't work. Okay. Great vessel injury. We're talking inferior vena cava or superior vena cava. There's not that much of the inferior vena cava that's in the thoracic cavity, but you can injury it. It could actually, you could have enough of an injury that it completely occludes it. What do we see? Pain, pallor, paresthesis. That's numbness and tingling, pins and needles. Paresthesia, pulselessness, paralysis. 5 P's of great vessel injury. Treat your patient for hypovolemic shock. Consider that they might have a hemothorax and they might have cardiac tamponade. Establish bilateral IVs and administer crystalloids. Again, practicing permissive hypotension. You'll get tired of hearing that in PHTLS when you get to take that. Pericardial tamponade, really the major treatment for that's going to be done at least in the ER, but probably in a surgical suite. Diaphragmatic ruptures, they're rare. When they occur, it's usually on the left side, not the right side. Liver protects the right side. I've even seen x-rays, and I couldn't find one for you, but I have seen x-rays in a doctor's private collection with a big loop of bowel sticking up into the chest cavity. And I've not heard this personally, but I have a pretty reliable friend who's a paramedic who says he's heard bowel sounds in the lower lobe, around the lower lobe area on the left side of somebody with a diaphragmatic hernia from trauma. And I've heard several doctors who have had long careers say that they've heard bowel sounds in the chest. Bad mucus, that's not good stuff. Acute phase at injury, latent entrapment of abdominal contents. So you have the diaphragm squeezing down on stomach, or more likely transverse colon up into the chest. And if you have that entrapment, you can eventually have necrosis of that bowel and have that rupture into the chest and have your patient develop septic shock. That's what that stuff's called. All right. Okay. It's hard to see that x-ray, so we're not going to stay there. Okay. Management, maintain oxygenation, elevate the head of the backboard. So we're propping stuff under that backboard so that we can get them in a slanted position so that hopefully we can keep that bowel from looping up in there. Bottom line is it's going to be tough to find these in the field. It's just going to be dang near impossible. NG tube, I can't feature that you're going to have a protocol that's not going to let you place an NG tube when you need it. We don't do that to each other in class. Esophageal injuries, you have an esophageal tear or an esophageal rupture, either one. Pleuritic chest pain, it hurts to take a deep breath, right? Sub-Q emphysema, associated tracheal injury. Because those things they're nestled right next to one another. There's not space there. They're right together. There's not much we can do for them pre-hospitally other than not give them anything orally. And in this case, we don't want to run an NG tube down there and poke that sucker out and make that rupture worse or that tear bigger. Tracheobronchial injuries, you have tearing in the bronchi or in the trachea, very high mortality rate, usually caused by penetrating injuries or rapid deceleration. Rapid deceleration, you will see this a lot, allows for rapid movement of air into the pleural space, causing a massive pneumothorax, which creates a really high pressure in the thoracic cavity so that blood can't drain down through the superior vena cava. And okay, I want to come back to how we treat it. Here's what it looks like. It's also called traumatic asphyxia or purple head syndrome. You can see this in a patient with a massive MI also. You walk in and here's this dead person who's purple, kind of purple blue from the nipple line up. It is kind of freaky to see. So let's back up a little bit. They got assessment and treatment out of order on this. I got to hurry. We're almost done. Okay. See that cyanosis, ocular hemorrhage. The whites of their eyes will be redded out. That pressure is not allowing that venous blood to drain out of the eyes, and it causes that the whites of their eyes to be completely red, swollen face, can't really make out their facial features. It's a horrible thing when you see it. Treat it with the BVM. Careful. I'd turn the PEEP down on this one, and I would be careful with my tidal volume. Transport to the nearest trauma center, spinal precautions, get them intubated if you need to, and high flow oxygen, get them to the nearest place that somebody can cut their chest open and fix it. And we made it right at 4 o'clock. So what are we going to do from here? I'll leave this on the recording. Hopefully these recordings work, and I'll get all this up to YouTube. It should convert them. It'll take till tomorrow for the converter to run these big files, and then hopefully I can get them up to YouTube and get the links to YouTube for you. And then all the videos that should have been in this, I'll get those onto Blackboard. Last thing, I'll get a quiz up for you. Probably, I'll try to get it this evening so that you have a couple of days to get it done. I'll give you till Friday to get it done. And then what else? Next Monday is going to be a long day. We'll have lecture in the morning and afternoon. So we're going to have 2 chapters next week. And then 2 weeks from today, you'll have an exam in the morning, lecture in the afternoon. All right. Questions before we go? Thank you for putting up with me. Go ahead.
What exactly is the name of the YouTube channel?
I'll send you a link to it so you know how to find it.
Okay.
Because I just set it up the other day and I can't remember. So I think it's my name, Richard Todd, but I'll see you guys later. Thank you. And I'll send you an email with links and stuff, as well as getting them into Blackboard for you.
Our quiz is just this chapter, right? Just
this chapter. I want to make sure you're getting all the quiz grades possible in here, and also breaking this up into smaller pieces so that you have an idea how you're doing. The exam today was really unfair because it's been 6 weeks since we did burns. 7 weeks. It's been 5 weeks since we did our last lecture, so it was horribly unfair. Everybody experienced about a 30-point curve on this exam because it was that unfair of an exam. So no big deal. Happy to give you I didn't give you those points. You earned them because you waited this long between the end of the lectures and your exams. So the system was screwed up, but we had to get labs done. So we'll take care. Everything will be better from here on. All right. Anything you need, let me know. Except money, I don't have that. And good looks, don't have that either. Y'all are all better looking than me, so we're good to go. All right. You guys have a good one. I'm going to shut this thing down, maybe.